Good afternoon. Hi, I'm Dr. John Comisi. I'm an associate professor of restorative dentistry, teaching here at the Medical University of South Carolina's College of Dental Medicine. And I also teach sleep medicine. I've been doing and teaching sleep medicine for quite a few years now. And in my private practice prior to coming to MUSC, it was a very important component in everything that we were managing our patients with. I teach for Sleep Group Solutions on sleep on a regular basis, which is always a lot of fun because we get to share my personal experience with doctors and staff members all over the country. And so this afternoon, what I want to do is talk a little bit about oral sleep apnea and dental symptoms that you may see. We get a lot of questions, especially during the lectures and with my students here at the college, about bruxism and how do you manage that? Well, of course, for years, you and I have been taught as dental professionals that you have some kind of grinding problem or you have implants placed or something like that, that you better put a mouth guard into place. And that can be problematic in that, according to some studies, there's a study done in the Journal of, let me get that for you, and the International Journal of Prosthodontics back in July of 2004, which talked about the aggravation of respiratory disturbances by the use of oral splint appliances in patients with sleep apnea. And in that study, some things were really brought out, which was very, very fascinating. Flat plane occlusal splint might actually be the worst thing you can do for your patients if they have any signs and or symptoms of some kind of sleep-related breathing disorder. And how do you know that they have a sleep-related breathing disorder? Well, unfortunately, you will only know for sure after a diagnosis has been rendered, after a sleep physician, a pulmonologist, or any other physician who's been trained in sleep medicine has a polysomnograph done or a sleep study done, typically done in laboratory. And it's from that study that's done overnight or multiple nights, depending on the need, that a diagnosis can be rendered. So there are a lot of patients who are unfortunately have some kind of sleep-related breathing disorder that really don't know it because of never being diagnosed. But they can present to your office with various signs and symptoms. A big neck, 17 inches or greater in men, 16 inches or greater in women. That's a lot of folks because, as we just learned recently by a recent study, 40% of the American population is overweight. That's a problem. So if you have a rather large individual, maybe they might have some kind of sleep-related breathing disorder. Well, what else could you look for? Tongue size. If you've seen tongues that are really large, that you have all kinds of scalloping around the edges of the tongue, or that seem to fill up most of the mouth, they may have a sleep breathing disorder going on. So that's the second thing that you can start to look for. And we want to be able to do that. Medications. If they're on multiple medications, especially for hypertension, diabetes, they may have a problem going on. If they've got something called the turkey waddle, you know how the neck down here gets really large, that may be an indication. That's called the cricomental situation fold. And if that is larger than about a centimeter, that could potentially, when you divide the neck from the chin down to the chest, that could also be a sign that there may be some kind of obstruction or sleep-related breathing disorder going on. So there's a lot of things that you and I are seeing every day. How about abfractions? Because that kind of forces that are occurring at night when they are micro-aroused by their disruption in good breathing and sleep will then also cause all kinds of problems and those kind of fracture-looking abrasions and abfractions that are appearing at the necks of all of our teeth. So these are things that you and I see all of the time. So why is an occlusal splint not a good idea if you suspect that a patient has any kind of sleep-related breathing disorder? Number one, it can worsen OSA because as you wear it, typically we make a mouth guard or a splint, typically it's only on one arch and it's flat. What happens? When the person goes to sleep, their lower jaw is able to go backward. That could block off the overall ability to breathe and exacerbate and contribute greatly to a sleep-related breathing disorder. So perhaps maybe we don't really want to consider that mechanism until we know for sure that there isn't a sleep-related breathing problem. That's when you have to say to yourself, gee, I think I better not prescribe this. Maybe I need to have a further analysis done. I would suggest, Mr. or Mrs. Patient, that we refer you to my pulmonologist friend who is a specialist in sleep medicine to evaluate you to determine what's going on and to make sure that any therapies that I can provide to you as your general dentist is going to be beneficial rather than harmful. So I would strongly advise developing a relationship with the pulmonologist or the sleep medicine professional in your community so that this way you can refer these types of patients to them for analysis prior to creating a flat plane splint, because it could be more harmful than beneficial in that circumstance, and you really don't want that to happen. We're getting kind of close to the end of this little video here, and I would suggest that if you have any questions and wish to learn more about sleep-related breathing disorders, how to recognize it, how to treat, etc., please reach out to Sleep Group Solutions at sleepgs.com. They'll be able to answer a lot of your questions. And perhaps one of these times or another, I'll see you out there and about. And if you have any questions, please don't hesitate to reach out to me as well via Sleep Group Solutions, and I'll be able to answer any of your questions. Thanks so much for being with me today.